Thank you very much, Martin. Thank you very much, Chairman. Well, this is a session that's devoted to these compounds. And it's what's called the elephant in the room. We are missing the compounds like, for example, we've just heard a lecture on the HEA now, and you realize the importance in measuring things. And nobody would ever have imagined, for example, that vitamin D was a problem, especially in the Mediterranean. Let's just quickly go to what vitamin D is. There's a number of vitamin Ds. Mostly it comes in vitamin D3 or vitamin D2. It's a fat-soluble steroid. Very few foods contain it. It's got a receptor. It is produced almost entirely from cholesterol, as you can see. Let me just get the hang of this. Sorry, backwards. I'll get there in the end.
We end
earlier. I need to get back. I've gone I want to start again. Maybe can you just give me a hand? Okay, this time is passing. Just click it. Right, that's it.
Yes.
It's got to load it. Good. Now this way is forward, right?
Yes.
Good. All right. I think I'm all right. Okay, so I just want to remind you that it's produced mostly from cholesterol. It has its receptor is very interesting because its receptor belongs to the same receptor family as estradiol and thyroxine does. And we keep on thinking of vitamins in terms of something that you get extraneously. Vitamin D is an exception. It's produced once again, like most of the steroids, from the basic cortisol and from cholesterol. Here is its metabolism, basically. And we have to get away from thinking that vitamin D is actually... I'm having real trouble here. I think it can only move forward.
We had the same phenomenon 2 years ago.
Have you got the control? Because whichever one I press, it's always going forwards. I want to go backwards.
Yes, with this arrow, I think so.
Okay, let's see.
Here should be...
Okay, right. I'm sorry about this. It's just getting the hang of it. There's no pointer. Okay, I'm all right. Thank you. Okay, right. So, sorry, I just got to go back to metabolism and I just get you to think that its metabolism is entirely produced in the body. A vitamin, as such, is a compound that you ingest, like vitamin C. Vitamin D is an exception. Vitamin D is 90% produced from cholesterol. So the trend nowadays is to call it a hormone and not a vitamin as such. If you look at the Endocrine Society recommendations, for example, I think we follow the American Endocrine Society recommendations. Then you regard as being deficient if you've got a vitamin D level that's below 20 milligrams, and if it's sufficient if you're between 21 and 29 and above 30. Or as we're going to talk about nanomoles, the normal range is between 30, although here it says 50, between 30 and 100. So even using that very wide latitude, we are finding that, in fact, there is a very huge vitamin D deficiency problem in the world. So just briefly catch up, because we had some confusion with our slides. Briefly catch up, vitamin D produced from cholesterol, similar receptor to the superfamily of receptors which estrogen and thyroxine belong to, similar sort of structure. It's produced from the same base cholesterol, like all the other sex steroids, and you can only consume up to 10%. You can't consume more than that. The rest you have to produce yourself. And we are now facing, according to the parameters from the American Endocrine Society, what is a major pandemic of vitamin D deficiency. And people say, surely there can't be so much vitamin D deficiency, they must be wrong. But then it's a lifestyle problem. We have to realize, for example, if you take a Mediterranean population, we were probably designed not to have such a conversion to vitamin D3 because our previous lifestyle entailed us living out in farms and fields or on the sea. And now suddenly, with a different lifestyle altogether, people are living more indoors, their jobs are indoors, they're less exposed to the sun, they're using sunblocks, and so on and so forth. All good things, but all having consequences from a metabolic point of view. Right, how does this affect fertility, for example? Because we're trying to see whether this is a role or not. So the classical role of vitamin D is in calcium homeostasis. But in fact, if you think about it, it might have some estrogen stroke SERMs-like activity as well. Certainly, the vitamin D receptor is present in both male and female reproductive tissues and in the pituitary. There are recognized roles for vitamin D in pregnancy and neonatal growth. It goes hand in glove with estrogen very often. There are vitamin D receptors in the vulva as well, as there are estrogen receptors, as there are DHEA receptors, and they're there in huge concentrations. And there are low levels associated with various morbidities, like in pregnancy, gestational diabetes, preeclampsia, and small for dates babies. We've spoken about the receptor. There seems to be a role in polycystic ovaries and endometriosis. And when we look at vitamin D and fertility issues, there are other gynae problems associated with low vitamin D levels. For example, women with fibroids have low vitamin D levels. Vitamin D may inhibit the development of endometriotic tissues. It could be part of the etiological mechanism for endometriosis because it might affect the immune reaction in ways that have been described, actually. And there's also an association with increased BMI, but that stroke association with polycystic ovaries. So there are widespread problems with the deficiency in vitamin D. And these are not surprising given the antiquity of this hormone stroke vitamin. In evolution, this is a highly conserved vitamin stroke hormone. And perhaps we might be able to think about it as a very primitive sex steroid. There have been studies where when vitamin D was replaced in vitamin D deficient women, progesterone levels went up by 13%, estrogen levels went up by 9% on average, and estrogen went up by 21%. These are very vague studies, but nevertheless, they do indicate that there might be some role in fertility itself. And this should not be surprising, given what we know about its physiology. If you're undergoing art procedures where every little bit counts, certainly it makes sense to have your woman being vitamin D replete because of the consequences we described earlier. We also want people to be, as well from the immunological point as possible, with vitamin D, like estrogens, having immunological repercussions anyway. So we have to remember that there is a high vitamin D deficiency everywhere. This was first actually identified in Saudi Arabia. It also says here in Iran as well. There's been various studies here that have shown, that have come from Iran, from these countries that were meant to be highly exposed to sunlight, that indeed this is a big problem in these countries as well. There's been a strong correlation noted between peripheral and follicular vitamin D stores. This is, follicular fluid has had vitamin D assessments carried out on it, and there seems to be a good correlation. And I have to just, as an aside here, now say that there are very reliable vitamin D assays which can actually measure vitamin D. So whereas before people used to say, well, you just give maybe 400 or 800 initial units, like any other hormone, the answer to that is you give what is necessary to bring that particular level within normal range. So I'll just carry on. Some people have even suggested that there's an increased fertilization rate with increasing vitamin D levels. And the worry is that if you've got low vitamin D levels in your follicular fluid, this might have some deleterious effects, some negative effects when it comes to fertilizing the oocyte itself. We'll just move on a bit, talk about vitamin D and polycystic ovaries. There have been a number of studies now that have shown an important role in the pathogenesis of insulin resistance in polycystic ovaries. There were 60 proven cases of PCOS. They were divided into 3 groups according to vitamin D status. The most severe and the ones that proved the most insulin resistant and the most difficult to get an ovulatory response from were the ones who were the most profound vitamin D deficiency, and where that vitamin D deficiency had been present for the longest possible time. And therefore, this association with polycystic ovaries. Other studies associated with endometriosis. Other studies that have linked polycystic ovaries with endometriosis developing after a certain amount of years, the two being linked together. There have been studies that have shown endometriosis to be much more common in women with polycystic ovaries. This has given extra evidence to the argument that really we should be not allowing people to have vitamin deficiency and should be aware of this huge pandemic that is present in our societies. There have, however, been no correlation at all between high AMH in women with polycystic ovaries and vitamin D deficiency. So AMH is a reflection of ovarian reserve, and it should be that. It's been a long day. So if you look at the role in disease of childbearing, there's been some work from Poland as well, which has shown that not only have we got problems with PCO, but we've also got problems, thank you, in women getting pregnant, so that vitamin D replete women had a much higher clinical pregnancy rate. We'll just move on, because there's some time. So you see there's lots of papers here linking up vitamin D with polycystic ovaries and with infertility. If you go through the literature and do a research, you get a lot of references coming up. Some papers are better than others, of course, but certainly infertility apart and assisted reproduction apart, we have this problem with polycystic ovaries, which is present in as much as 20–25% of our population. It is not always pathological, but certainly if we can prevent it from having its clinical manifestations with simple measures like vitamin D or maybe glucophage or whatever, then we are doing a good thing. What about in men? In men, quite a number of studies are needed, yeah, but there is certainly evidence, mounting evidence now, that there are lots of men who are indeed vitamin D deficient, and that correlates with their sperm counts. And not only does it correlate with their sperm counts, but it also correlates with mobility and morphology in sperm. And there are lots of interesting studies now that look at vitamin D levels, not just in peripheral levels, not just in serum levels, but also in seminal fluid levels. So just mirroring what we discussed about the follicles now, there is some suggestion that if you've got vitamin D levels that are low in your seminal fluid, then this is going to reflect on certainly the motility, but also the morphology of the sperm itself. So, and here we are, some of the studies that have shown this. And there's also been suggestion that vitamin D and testosterone levels go hand in glove. So vitamin D levels might also reflect testosterone levels for some reason or other. But actually, if one thinks of them in terms of sex zeros, then one would know that probably they're all related. Now, the problem with vitamin D, as always, is dosage. Dosage has been our big bugbear, because so far, most studies and most recommendations have been to give 400 to 800 international units a day. 1,000 units is considered to be a high-ish dose. Now, I'd like to show you that this is not so at all, that all our studies are probably flawed because they've been underdosed. Now, the upper limit of tolerability is not 4,000 a day. I'm sorry, there's a mistake here. It's more like, it's something like between 10 and 15,000 international units a day. Some people say it's even higher. So it's very difficult to have intoxication. And you can, really, intoxication happens at levels of in excess of 150 nanograms per mil. And in order to get that level, you've really got to have very high levels of non-commercially available vitamin D. It is possible to take tablets once a week of vitamin D, and the levels there recommended are about 50,000. So really, we do not recommend you take the dose of once a week, 50,000, and you go and take it every day. This is not a good idea. So like everything else in life, you've got to take the right dosage at the right time and not overdose. I mentioned briefly the effects on pregnancy earlier, because this is a very broad talk. Certainly, vitamin D levels have been associated with preterm delivery, and some work from Poland, once again. With proper supplementation, you can actually reduce the incidence of preterm delivery, in one study by 50%, infections of the mother by 25%, thus emphasizing the role of vitamin D in the immune response. And also some comorbidities seem to be lower if you're vitamin D replete, with diabetes mellitus, which we spoke about earlier, hypertension and preeclampsia being reduced. So there's a lot of work out there. It's just a question of getting it all together and looking at it. We'll leave endometriosis to a side for now and speak about bones. Okay, now bones osteoporosis has been a big problem. Does vitamin D have a role in fractures? Well, its cardinal role is to sequester calcium and deposit it in bones and to be associated with calcium metabolism. So now we're going back two bases and saying, listen, it's useful in all these other conditions that we've just been discussing. But how about the original idea that vitamin D was useful in bone metabolism? Well, on its own, it's unlikely to prevent fractures and vertebral fractures on its own. With calcium, however, in the elderly, there's been studies that have shown this combination to be useful. But once again, the big problem is dosage. Calcium on its own has been shown to be somewhat useful because calcium itself is an antiosteoclast. But where does vitamin D fit into this equation? Well, as you can see from most studies here, and this is Bishop, who's a very big proponent of vitamin D, Bishop Ferrari, he actually was able to show this study here in 2005 that with reasonable doses, not high levels, just about 800 international units per day, there was a shift in favor of vitamin D as opposed to in favor of control with some of the studies that he looked at in this particular meta-analysis. What about the fracture risk with vitamin D and calcium? Once again, you can see a number of studies are to the left. And here, as late as 2005, it still wasn't realized as to what the correct dose that we should be using was. So in many of these studies, the upper limit was about 800 international units, possibly 1,000. And I say this because, once again, you have another study in 2009, where here the levels have gone up slightly to about 800 international units per day. And once again, you've got conflicting results. If you look at the Bishop ones, where we have higher doses, then we have they're more in favor of a lowered risk. And we start saying, well, what's going on here? And we've just had Boland's meta-analysis it's just been published in the Lancet, and here there were 81 studies, and this is only a small group that I'm selecting here, and these are the ones who are on 1,000 international units. The 1,000 international units clearly favored the high versus the low dose. If you can look at that, you can look at the fracture rates on the side, and here there's a favor in favor of the higher doses. The higher doses here were just above 800 to about 1,000. They weren't any higher than that because they are older studies. But you can see that there is a suggestion here that with higher doses we are actually starting to see some light and to try and solve the problem. You can see the total was 20 fractures versus 32, and the RR was 0.61. So there were comments on this paper from Bishop again, who went attacking the paper, and he said regarding Boland et al.'s paper, 81 studies, the studies were all vitamin D doses from 800 to 1,000 without calcium. See, these were without calcium. Now we tend to use calcium as an adjunct, but of course calcium had some bad press, and people are very careful. So with doses, so this is a different version. So with doses lower than 800 or less, there's a misprint there. There were no significant differences in total fractures, total hip fractures, and total falls. But there were 11 studies out of the 81, just 11 studies which had vitamin D levels of greater than 800, between 800 and 1,000. And in these particular papers, there was a significant reduction in total fractures and falls. So this suggested that with higher levels, we are starting to get somewhere. But there are no studies in the current dosage that is used by many people of 4,000 international units of vitamin D3 a day. And there are no studies which include vitamin D serum levels as a routine, although there were some suggestions in some of the previous studies I showed you. And where does this magic 4,000 international units figure come from? It comes from the realization that you can increase by 10 nanograms per mil of vitamin D per day by giving 1,000 international units. So as a rule of thumb, 1,000 international units orally is translated into 10 nanograms per day, a 10 nanogram increase. So there's no excuse anymore now to give low doses. If you just give 10 nanograms, you're going up from 20 to 30. You're still way below the normal level, let alone the median level of 75. So really, just like you do with thyroxine and just like you do with estradiol, all you have to do is give the correct dose. And we are concluding now. So we just realized that vitamin D is a hormone with multiple physiological roles. We've shown there's a correlation with polycystic ovaries and BMI. I think the therapeutic dose needs to be looked at very, very carefully. With infertility, we need to look at it. If there's a deficiency, it needs to be sorted out. And certainly, if we're looking at fractures, we need to have studies that look carefully at appropriately replacing the deficiency that is present. There is no excuse now to give lower doses because we can measure serum levels. Thank you very much. Sorry about my slides.